Dr. G Vijayakumar and the scientific committee members for having given us this nice opportunity to talk about the interrelated topic of various organs, and that too in a just like a 3D, here you have 4D, and that's what we are going to discuss today. So thank you, and probably the topic is CRM, Holistic Care.
So thank you very much to the organizers and Dr. GVK sir for having me here today. So this is a last minute Jugalbandhi. So the Jugalbandhi that happens at home is going to be extended over here as well. So the term Jugalbandhi comes from Indian classic music, where two musicians come together to either play an instrument or sing a song or something like that as a very collaborative and rather in a competitive manner. So this is not going to be competitive, this is going to be a collaborative Jugalbandhi on the cardiorenal metabolic syndrome, which we are all aware of and which we all deal with every single day, and what really we need to do more in order to give the benefit to our patients. So overall, the cardiorenal metabolic syndrome is not a new syndrome. This has been there ever since we coined the term metabolic syndrome, syndrome X or Reeve syndrome. I'm sure all of us would have actually studied it for exam purposes. But back then, there was no much of recognition. There was a lot of controversies as to if really this syndrome exists. But now, decades later, I'm sure all of the senior faculties would agree, initially we never had a diagnostic criteria, then everything came in. But now we have redefined, probably renamed the same pathological abnormalities into this cardiorenal metabolic syndrome. And we have three important components that contribute to this syndrome. So would you like to go ahead and define how we really, when do we really call it as cardiorenal metabolic syndrome, and if we have any guidance to go by it?
American Heart Association tells you that cardiovascular, kidney and metabolic syndrome, or the CKM, or sometimes it is called as CRM, as an interaction and the pathophysiological connections among the cardiovascular system, renal system and metabolic risk factors. And this leads to a multi-organ dysfunction or failure and to a complex clinical presentation. We have always been seeing, just like an elephant is seen by a 4-blind person, individually looking at organs. And today we have the holistic view of this particular metabolic syndrome. And the components of this particular syndrome is a cardiovascular, renal and the metabolic. In the cardiovascular you have entities like hypertension, coronary heart disease, atherosclerosis, heart failure, acute coronary syndrome and atrial fibrillation. Heart failure without even coronary artery disease is little pathognomonic of diabetes. And looking at the metabolic, the diabetes or a dysglycemia associated with dyslipidemia, non-alcoholic fatty disease, as well as obesity. Looking at the kidney problem, chronic renal disease, proteinuria or albuminuria, hyperkalemia, and also anemia. And all these things refers to an interconnectedness of cardiovascular, renal and metabolic diseases. Looking at the prevalence, as you see here, these are not the rings of an Audi car, which should be 4. There are only 3 rings here. And these 3 rings engulf all the particular disease entity as an individual percentage of 6.8% and 7.5% and 3%. However, the combination of all these things as well as the individual ratio between these two make it to remember as 1.5% of all these 3 things together. Next slide. And how does it really happen? So the primary problem is the adipose tissue which becomes dysfunctional. Adipose tissue really means the place at which the fat should be deposited. And I still remember my teacher, Professor in Kasirajan, who used to say, fat at respective positions are always good to look at. And maybe in a medical angle, it's always a fat at the right place is very good as a healthy index. But once there is an overflow of fat deposition beyond the conventional side, there's an overflow which goes into the kidney, which goes into the liver, pancreas, which is called as the twin cycle hypothesis, and also the muscle. This causes insulin resistance as well as the problems related to the complication of these diseases. And ultimately, the fat cell, which was supposed to be only a storage of calories, has now become an endocrine organ, wherein you have a lot of adipokines, cytokines, which are very active and the causative agent for all the problems. So ultimately, it results in inflammation, oxidative stress, insulin resistance, and vascular dysfunction. All these things result in looking at the cardiac problem, of atherosclerosis, MI, all these things. Plus, you have the metabolic components of hypertension, dyslipidemia, metabolic syndrome, diabetes, and also affecting the kidney, producing all the problems. And the interesting point is, this renal problem through neurohormonal or directly involves the heart. And that is why nephrologists always used to say, renal failure patient does not die because of end-stage renal disease, but he dies of a cardiac problem. Something like that, there is again a reversal of fat problems leading on to metabolic problems as well as leading to heart disease. And I'll tell you what this heart thing does for the metabolic activity in the next few slides. Next slide. And what do you think that this is the most important driver of cardio-renal metabolic syndrome? The culprit is the fat, which I have already told you, and this particular fat producing all these adipokines affects all the organs, producing metabolic abnormality due to skeletal muscle deposition, also due to the vascular endothelial dysfunction, and once endothelial dysfunction happens, that spoils the entire vascular tree. So I always used to say, if Aware was alive, and if he had the opportunity of wishing Adiyaman, he would have said, may your endothelium be healthy. So that means you are perfectly healthy. So such a thing is about the endothelial dysfunction. Then you have the kidney and also the heart, which is affected by all these things apart from atherosclerosis. Next slide.
So basically, the sidekick of being a sidekick, the adipose tissue was initially recognized, but for now we know it has become a hero of the entire cardiorenal metabolic syndrome, and that's the reason why it draws attention so much, and that's the reason why we also have a lot of evidence to say that weight loss per se can have an impact on the cardiorenal metabolic syndrome. So there are a lot of conventional risk factors, as we all know: diabetes, hypertension, dyslipidemia, sedentary lifestyle, poor dietary habits, smoking, and all that. These are all the conventional risk factors that goes with any component of this cardiorenal metabolic syndrome. But however, there are some importance that has been given to the genetics of it. Because not all obese individuals do develop metabolic syndrome. I'm sure you have all seen a lot of obese individuals. They don't have even diabetes or pre-diabetes. But the thing here is, there is an underlying genetic predisposition for any individual to develop this cardiorenal metabolic syndrome. So all the mitochondrial proteases, lipases contribute significantly when they are mutated to the development of cardiorenal metabolic syndrome. So that is the reason why some progress, some do not progress. Some develop complications and some do not develop complications. As of today, we don't have any modes to really look at the genetics of the individual, but that needs to be kept in mind, because many times just because they're metabolically healthy, we cannot say that they are perfectly alright. Now, beyond these conventional risk factors, there are certain risk enhancing factors for the CKM syndrome. One such is any inflammatory condition. For example, you have rheumatoid arthritis, psoriasis, HIV, lupus. Any inflammatory condition predisposes these individuals to develop cardiorenal metabolic syndrome. And as an ethnic individuals, as South Asian ethnicity, we are genetically prone to develop CKM. Beyond all this, you have mental health issues, sleep disorders. The most underestimated component is insufficient sleep, and also premature menopause, adverse pregnancy outcomes, PCOS. All these things come into play when you do not have the traditional risk factors. These factors are good enough to push these patients towards cardiorenal metabolic syndrome. So that brings us to the understanding of cardiorenal metabolic syndrome as the interplay of many components. What we know as of today is the cardiorenal and metabolic. How much more components are going to come into play, we really do not know. We have expanded the pathophysiology of diabetes from triumvirate pathology to ominous octet to filthy 15, and it's never ending. Similarly, there may be more and more components that could be joining hands in this interplay. Now, there's something that we actually have understood over recently. Traditionally, diabetes was considered to be the cardiovascular risk factor. We know that every specialist, like cardiologist, nephrologist, would blame the diabetes control to be the main reason for landing up with them. But now we have growing evidence to say that the cardiac dysfunction and renal insufficiency can potentially alter the metabolism, contributing to the development of new onset type 2 diabetes. So it's not that diabetes causing cardiac and renal dysfunction, but rather the other way around. So there are a lot of mechanisms that has been proposed. The sympathetic nervous system activation, RAS activation, the glucolipotoxicity, endothelial dysfunction, inflammation, oxidative stress, all occurring merely due to the cardiovascular dysfunction and renal insufficiency, can potentially contribute to the development of type 2 diabetes. So it's no more a unidirectional relationship. We understand that there is a bidirectional relationship. Diabetes can cause cardiovascular disease with all the pathological abnormalities that we already know: insulin resistance, hyperglycemia, oxidative stress, dyslipidemia, our age accumulation, most importantly mitochondrial dysfunction, which we know for sure that there is a very, very high risk of patients who have mitochondrial dysfunction to have both diabetes and cardiovascular disease. So it's a bidirectional relationship. So that is the reason why a multidisciplinary approach is required to treat the cardiovascular disease, treat heart failure, at the same time treat diabetes and achieve the glucose control. So now that we have understood about the individual components, how they really contribute to the burden, how they are interrelated with each other, would you like to come in and say that how these components progress? Because we know that these components are very progressive, and how do we really risk stratify these individuals for whom we actually label them as CKM syndrome?
Yes, cardiorenal metabolic continuum is a long story. It starts with the risk factors of hypertension, diabetes, obesity, and age factor. It has two branches. Into the endothelial dysfunction looks into the microvascular complication progression, as well as atherosclerosis and LVA and cardiac problem progression. This need not be always in the same order. It could even skip. Another important thing is that this endothelial dysfunction can lead to microalbuminuria, macroalbuminuria, proteinuria, and end-stage renal disease. So also the cardiac problem, which has been started or triggered even from birth, is worsened by the genetic and other risk factors, as she already pointed out, leading on to an infarction or a stroke. Then the ventricular musculature gets remodeled. Then you get dilatation, heart failure, even dementia, and finally it ends with cerebrovascular death. So all this you could even skip one stage and reach the end point. So ultimately, this is a long story wherein you might identify a patient at microalbuminuria stage or even at an end-stage renal disease. So our idea is to identify this risk category and probably prevent this progression of the CKM. And this is a very common slide that we have now come to see again and again. This is a wonderful stage. So this is 0, 1, 2, 3, and 4. I always remember that you are 0 foot deep into the grave, 1 foot deep, 2 feet deep, 3 feet deep, and 4 feet deep in the grave, and ultimately end up with a burial. So here we should be very happy that we are all in, at least in this particular risk category of 0, wherein the lifestyle is very important. Good eating pattern, good sleep of at least 7 to 8 hours, and good exercise, checking the blood glucose often, weight maintenance, lipid abnormality control, and hypertension control, and avoidance of smoking. So if you go ahead with all these factors, you remain in stage 0, and by chance, if you start becoming obese in an apple-shaped obesity, your lipids, adipose tissues start creating the problem. So this causes an impaired glucose tolerance, or what you call the metabolic syndrome in simple words. Then you are already 1 foot deep. Now we are going to second stage, wherein you are 2 feet deep. So here, hypertension and kidney disease due to other reasons, leading on to metabolic syndrome, dyslipidemia, and development of diabetes. This pushes the patient one more stage, and this is little difficult stage to reverse. Maybe if you identify these patients here, it's easier to reverse it. But as stage goes on this particular side, reversing it becomes little difficult. Next, you get the subclinical CVD in the CKM syndrome. So here you get the abnormality of ASCVD or ASCVD risk progressing to ASCVD, and also the subclinical heart failure. When heart failure was mentioned with diabetes, those days when we were taught that only after myocardial infarction the patient will develop heart failure. If it's going to be ischemia, no failure. You can't explain that. That was the concept. Then they said this kinetic segment, all these things can also produce the heart failure. But now we have understood with a clean coronary, due to the defect in the myocardium, but the myocardial relaxing factor, you get into heart failure, preserved ejection fraction or reduced ejection fraction. So now we are already a little more deeper, and finally you get the stage 4, wherein all complications of cardiac, and it's almost like an endpoint of heart failure, CHD, arrhythmia like atrial fibrillation, PVD, as well as related to stroke. So finally, the patient goes in for the burial. So maybe if you could identify this and maintain that, that would be the best, or at least at this stage you could reverse. Beyond that, it is difficult to reverse. Now, looking at this particular DT, we'll have to have the risk factors so that we'll be able to identify them at the stage 0 or at least stage 1. And how do you go about categorizing them and then screening to identify this problem quite early?
So as we all know that prevention is always better than cure. So to prevent, we need to screen, we need to identify those at risk quite early so that we are able to modify the risk factors in them and to prevent this ultimate barrier of beyond stage 4 of CKM. So there are two categories of screening where we have an approach towards younger individuals who are less than 21 years of age, and this screening approach has been put forward by the American Heart Association. So below 21 years of age, our intention is to identify risk factors and to cut down the risk factors. So for example, we screen them for overweight or obesity, blood pressure, lipid profile, behavioral issues, and more importantly, the dysglycemic pattern with fasting plasma glucose, HbA1c, and oral glucose tolerance, and also ALT. So the younger the individual, the more is going to be a screening approach for risk factors. Of course, when the age goes above 21 years of age, we understand that these patients would have potentially developed one component at least, and therefore the screening approach changes to identifying the established component of the CKM syndrome. So beyond all whatever I have said with regards to the risk factor screening, the most important screening is to screen for all the metabolic syndrome components and most importantly MASLD. Now this screening, even though it is negative, every 1 to 2 years the screening needs to be continued because as the occurrence of type 2 diabetes comes quite early, all the components also occur early, and so no age is actually free from developing a CKM syndrome. So that is the understanding that we should have when we deal with patients, even with young onset diabetes or when even a 25-year-old is obese, we need to keep in mind to screen for the CKM syndrome. However, screening itself has a lot of gaps. Most of the times we are not able to screen these patients either because of loss of insight, convincing the patient who just walks in as an attendant to a diabetic father or mother is very difficult, especially to tell them that they are obese, to tell them they are at risk of developing the same complication. But however, this has to actually go in because later this patient is going to thank you. So the lot of gaps still exist in our population. We have the difficulty to screen them early because nobody would agree to screen somebody who's 18 and 20 years of age unless they have some symptoms. So, and this is going to be really helpful, especially when these women go and go forward to planning pregnancy and all that. The second thing is screening for the metabolic risk factors and CKD. Most of the times we always go with creatinine. We need to understand that there is a little discordance between eGFR and creatinine. Sometimes creatinine is normal, but you would still have a low eGFR. So calculating eGFR in every single individual, especially who are at risk of developing CKM, is really helpful. Subclinical CVD, though we talk a lot about it, how many times do we screen these patients with ECG or an echo, or even send them for a treadmill test when in doubt? So subclinical CVD diagnosis is always done less and many times is brushed under the carpet, so that needs to be improved. The social determinants of health is gaining importance now because we know that man is a social animal, so we need to look at the other aspects of mental health, physical health, environmental health. That really helps these individuals to change their environment so that they don't progress into the subsequent stages. So having known about the CKD syndrome, looking at the pathophysiology, what really drives it, and how do we really screen for them, once the patient develops a CKM, say for example the patient has progressed from stage 0 to stage 1, how are we really going to address these patients? Do we have adequate drugs that can actually modify the CKM, or is it just the lifestyle modification which is going to be useful for them?
Of course, lifestyle modification is important, but beyond that you need medications. And the list of medications shown here were never available when we started our practice. And whatever drugs which we started practicing are not here in the particular list. And these are medications which are able to give you a holistic management. So that is what is really important and the need of the hour. So here what happens, the targeting new drugs for this entity are almost like an omnipotent drug. So they are not only useful in metabolic derangement correction, like SGLT2 inhibitor, GLP-1 receptor, or tirzepatide. It corrects metabolic dysfunction, which is helpful in preventing cardiac problems like atherosclerosis, hypertension, heart failure, and myocardial dysfunction. So also here, all these things help in reducing the cardiac renal load, which is also a causative agent for the cardiovascular entity. So these drugs, maybe finerenone is a little exceptional. All the other drugs are almost common. So it's almost like amounting to the Vivek comedy you might have seen. One person says, I have got a hard of hearing, I have got this, I have got piles, give me one medication. No? In days to come, we will have one medication to be able to correct every metabolic disorder. So that is the next slide. So with that, you have the list of drugs which are available in this particular regard, and to correct the metabolic target, all are useful. The type 2 diabetes, everything is useful. And today, our expectation is also increasing. So just like nobody is contented. No? So what happens when you just give a drug, just a parenteral, you always wish to have a oral medication. So once you oral medication, you are happy for some time. But beyond that, you feel, oh, this does not reduce the blood glucose. Yes, finally you arrive at a very powerful drug. Then you don't want to have hypoglycemia. Okay, that also is taken care of. And beyond that, you say not only diabetes control, but also other comorbid conditions have to be answered. So when your expectations are increasing, the molecules are more changing, and they are able to come up to our expectation. Thereby, metabolic targets are achieved by all the four. At the same time, hypertension, CV death also is achieved by all the four. And also renal targets also are almost everything is helpful in this regard also. So that is why we are trying to make it a little more simplified, that all the pathogenic abnormalities in the CKM are having the same causative phenomena, and once you correct that particular entity, you will be able to achieve 4. So maybe it's almost like 2 at one stroke, here 3 at one stroke. Next slide. And one more interesting thing is bariatric surgery, which has given a very gross weight loss, has been helpful in reversing all these various stages of CKM. You just look at this, with 28% of patients with waist weight reduction, they were able to achieve this progression and also reversal from CKM stage 3, stage 2, as well as stage 1. Stage 1 is not that much beneficial with medication, with bariatric surgery. So bariatric surgery, which mainly tunes to weight reduction of more than 28%, is able to give you a lot of benefits in reversing this particular entity. So you are out from your grave and you are able to walk around. So that is the advantage of that particular entity, which our medications might be able to give you, might not be able to give you, only time should let us know. Now you go ahead with the algorithm of treatment of CK.
So the weight loss is the key intervention that really helps us to retard the progression of CKM and possibly look at reversal of CKM. But to achieve that reversal or remission, the weight loss that is actually required is more than 20 to 25% of total body weight, which as of today we are able to see with bariatric surgery. But of course, in days to come, we will have data with tirzepatide and retatrutide, which is going to come into the market soon, and that could really achieve 20% of body weight loss, and that's going to really help us reversing the CKM or probably at least holding on in that stage without at least progressing, which could really help these patients. Now, the American Heart Association has put forward this management guidelines in the form of algorithm. So, stage 1 to stage 3, the first important thing is for weight loss. So, that weight loss goes with lifestyle modification and choosing drugs which can help you in losing weight, which includes SGLT2 inhibitors, GLP-1 receptor agonists, over and above metformin. So metformin still has a role to play in these patients with CKM syndrome in stage 1. Now, once they move to stage 2, where they already have established risk factors for CKM, the management is mainly targeting individual components, no more risk factor management. So, the lipids have to be controlled with statins. You may as well add fibrates when you have the triglyceride more than 500, and probably add on an eicosapentaenoic acid or acetamide, because triglyceride still holds a major target when it comes to lipid control. The blood pressure control, what we have been using currently, the first line choice of drug would be ACE or ARP inhibitors, followed by beta blocker. So whatever it is, the blood pressure needs to be under 130 over 80 millimeters of mercury. Now, looking at CKD, treating the albuminuria is the core, and treating albuminuria with all the pillars that KDIGO has put forward with SGLT2 inhibitors, Finrenone, over and above the maximum tolerated dose of ACE and ARP. So with this, and with drugs that can help us to modify weight as well as achieve a better glycemic control, stage 2 can be taken care of. Now, stage 3 is when patients develop a subclinical CVD or a CKD, and for them, the management varies depending on the coronary calcium score. So, the coronary artery calcium score, if it's more than 100, these patients become at high risk, and therefore these patients have to be treated as with CVD and to reduce the risk of progressing into or having a cardiovascular event or succumbing to a cardiovascular event. Now, heart failure, again the 4 pillars of heart failure which you already know, also comes into place when we are dealing with stage 3. Now, stage 4 is whatever we have done in stage 1 to 3, and beyond that, in these patients, the cutoffs for achieving glycemic control, achieving weight control is much stringent. So you achieve a tighter control, triglycerides less than 200, blood pressure less than 120/80, and the HbA1c as close to 6.5% as possible. So overall, we have gone beyond looking at the numbers with regards to the fasting, postprandial and HbA1c control, especially when we are looking at CKM modification, where the patient comes right at the center and not somewhere else, and we try to manage lifestyle, pharmacological intervention and surgical intervention as and when needed, and the cutoffs of BMI varies because the AHA puts forward of BMI more than 30 with comorbidities go for bariatric, more than 35 even without comorbidities go for bariatric. But now we know that our patients when the BMI is more than 25 itself, they have a very high risk. So the Indian modification needs to be done before we really risk stratify these individuals. So with all these positives, we still lack in certain things why we are not able to achieve the best management that's possible for CKM. So would you like to say what else the future holds for us?
Yes, that's what I was just telling you. Our expectations have been increasing. And the medications also have come up to our expectations, if not absolutely, relatively. And now you have a problem related to, you need some normal medications with CMR benefit. And also the combination therapy, we are not very sure about any given study. And integrated management of CMR disease and risk stratified personalized care, as you rightly pointed out earlier. And drug prioritization, which drug to be given first, and which drug to be used as second one. Those days we didn't have any problem. Metformin, sulfonylurea, insulin. That is simple. But today you have so many drugs, so putting them in order, putting them together becomes a little defective. Now looking at the future is like a wishful thinking. It should be something like a utopic land, wherein you should have drugs which are able to completely control the CMR. And further efficacy and safety data you should have. And better understanding of the drug mechanism of action. And outcome trials are lacking. And also multidisciplinary approach. And this point always reminds me of my professor Dr. Sundaram, who always used to say, total diabetic care. The name may be different, but this is a concept he was talking in 1991-92. And today we are talking about the holistic CKM management. It's almost the same. And beyond that, the risk score validation, like what we have Mohan's risk stratification, if you have that one, it would be easier for us to screen. And clinical trials with specific population who are women, young persons, particularly as you said, below 21, is again becomes a little more difficult. And head-to-head drug comparative analysis also would definitely give us little more in view. So dear friends, to summarize, a lot of data support the existence of substantial overlap between metabolic, cardiovascular and renal disease. With onset of one, increases the risk and worsens the outcome of the other. So those days when we were quite young, myself and my wife used to go for walking and running in the race course, which is very close by to our house. But what happened, she became busy, I became busy. So, both of us did not do any exercise. Then we decided one thing, we will have a diverse in this particular entity. So you do exercise, but whatever time you have, and I will do the exercise at whatever time I get. So we started to do that, and probably we are trying to avoid the 1 foot deep grave even today. The three entities share a common pathophysiological mechanism or a common soil hypothesis. And this results in a vicious cycle of worsening the disease processes, thus increasing morbidity and mortality. So lifestyle changes and lifestyle changes, weight loss and CRM-friendly drugs definitely would be able to reduce CRM in days to come. And targeted pharmacological intervention to interrupt this detrimental crosstalk and improve clinical outcome holds the future of CRM management. So sooner or later, we will be getting more number of drugs which will be able to act on all these factors with one single drug, and probably we will start living eternally. So thank you for your patient listening, and also Dr. Vijayakumar and the team for having given us this opportunity to be with you and to share some new insights. Interaction. So thank you.
Thank you very much. Thank you very much.